Hi, welcome to series three of Continuing the Conversation with Sadie. Today's episode is titled Fearness Medicine, Power, Safety, and the Future of Care. And there is no one more fitting to explore that theme than my guest, Baroness Clare Gerada, DBE. This is amazing. Clare is a GP. Sorry, I'm starstruck.
Don't
A
worry.
former chair and president of the Royal College of General Practitioners, co-founder of founder of the NHS Practitioner Health Programme, and a national leader in addiction, mental health, and professional safety. She leads the primary care gambling service, is patron of doctors in distress, and now serves, and get this, as a crossbench peer in the House of Lords. But titles alone don't capture her impact. Dame Clare, is a fearless pioneer. She names what others avoid. She protects the people who protect the public. And by that, I mean this lady dedicated her whole career to championing both patient care and mental health of healthcare professionals. And she spent decades reshaping the culture, safety, and emotional architecture of care. Clare, I'm so glad you're here. Welcome.
That's an amazing introduction. Whenever I hear anybody introduce me like that, it must be something very common amongst people that I can't associate that introduction with me, who, when I was at school, wasn't even allowed to be the milk monitor. And if you're of my generation, you'll know what the milk monitor was. And it does always surprise me, really surprise me, when I hear these accolades being read out, that actually is me.
I feel absolutely honoured to have you here today, and I love talking to all my guests. You all have so much to offer, and to say that it doesn't sound like you, that just shows how grounded and down to earth you are, which just makes me love you even more. We're going to get going. I know that you've worked across primary care, mental health, addiction, and professional regulation. You've seen the system at its strongest and at its most fragile. But I want to begin with the heart of today's title, which is Fearless Medicine. When you strip away the policy language and the slogans, what does good care actually look like in practice? What does it feel like when a system is genuinely safe for both patients and professionals?
Yeah, I mean, that's a big question, really. At the individual level, with you and me in the consulting room, what does good care look like? And good care looks like somebody who listens, somebody knows what to do, somebody who's there. So,
yeah.
And within that is all the wraparound, compassion, caring. But if you don't listen to a patient, if you don't know what you're doing, and if you're not available, in other words, you can't actually access a carer, then those three things just fall apart. And what actually good care also is about, it's not about excellence, it's about good enough. And that's a term that comes from a psychiatrist and a pediatrician way back when, Winnicott, who talked about mother. You don't have to be perfect, you have to be good enough. That doesn't mean you don't get as good as I can deliver. But what good care means is about being there and being attentive in the consulting room and knowing what you do. Now, what does good care look like at a policy level? At a policy level, system that allows me as the clinician to do that well. And so policies that allow me the time, the space, the freedom, so not too by protocols and guidelines. And that's what
so glad you said that.
And sadly, at policy level, that is largely lacking, certainly in my own profession in general practice, where we don't have the time to care. We might know what we're doing, but we don't have the time to be attentive. And we are constrained by endless tick box diktats that we have to do because that's the only way we get paid. So I hope that sort of answers your question.
It does. And I'm very, very excited hearing your answer because with past guests, other experts, they're all saying the same thing. There's not enough time. People feel rushed. It's almost how I would sum up a general theme I'm picking up on is presence over perfection.
That's actually
to
right.
hear that from you.
There is no such thing as perfect medicine. And the public know this. I've made errors. Apologise to patients, and may not catastrophic errors, but errors. What they want said is a doctor that's there, a doctor who knows what they're doing, and a doctor who is listening. And we find that in surveys, by the way, so it's not just me if you actually strip that back. And time-wise, you see, I was told by a very wise doctor many moons ago that as a GP, you can only really deal with 60 souls in your, 60 of patients in a week. There's something finite amount of attentiveness I can give. And once you are over that number, and you might say, how does it come to 60? Well, because that's about right. If you think about morning and evening surgery, 3.5 days a week.
Yeah.
Right.
That's still a lot.
It's still a lot. And once you get beyond that number, I might still know what I'm doing because that's inbuilt in my training, but I won't be as compassionate. I won't be as attentive.
Because you're burning out.
You're burning out. So those three things are also what's necessary. And policymakers have to make sure that we can deliver that.
Yeah. No, thank you. Thank you for sharing that with us. You've always been clear that culture is created by behaviour, not documents. And we've touched on that a little bit just now. From your vantage point, what cultural conditions truly protect dignity, autonomy, and safety?
Well, it comes back to let's put. I think if I could turn that round, what cultural conditions impede that? I think the cultural conditions impede that are over-reliance on or a fear of litigation, a fear of enough time to explain properly to patients what we need and what we think should happen. An artificial barrier between patients and the carer. So we always talk about
I love that.
I believe in patient-centered care because I don't think being a patient is part of a dyad. It's part of a relationship with a carer. And therefore, it's the dyad that's at the centre. Both of you trying to work together to come to a decision about your health. So the cultures that support that are cultures of transparency, cultures of honesty, cultures where taken out, where you can admit to errors, where you can go and talk to your colleagues and say, I really don't know what to do. Those are the cultures that actually promote safety. Certainly within the consulting room.
I love that answer. I knew you'd get straight to the point. I was so excited about this conversation.
I worry about the constant drive for guidelines and protocols and mandatory training that somehow is used as a proxy for, well, if you put these in place, that means we'll get the culture and the behaviour right. No, you don't. What you do is you further clutter up the space of the patient and the doctor, and you further clutter up the ability of that doctor to go and seek help when they need, or the nurse to seek when they need help, because it's the time taken with all of the, one single patient might have 15 different clinical guidelines. Well, you can't deal with that in a consultation.
No. I love that. And coming from yourself, I hope all my listeners have listened to every word you just said, because it echoes a lot of what a lot of people are saying at whatever levels of care. And this is all about the human side of care. So that's fantastic. Thank you. Carrying on from that, I love the way you flipped that around. She still answered it brilliantly. I just wanted to know, what are the early warning signs when a culture is struggling?
Well, I think they're right. I think complaints are, I know we take complaints as being gifts, I think feedback is a gift. But I think when you see a rise in complaints, a rise in an organization having internal struggles, so rise in
Mm-hmm.
grievances, rise uh, in the sort of complaints between staff pushed up the line. I think that is a sign that an organisation is struggling, because it's a bit like a marriage, Sadie. Really, what's a sign of a marriage failing? A sign of a marriage failing is when you bicker about trivial things. Or when you
Yeah.
don't have space to sort things out, when you don't want to sort things out because it's too difficult. And I think that's the same in an organisation. It's when you don't have the time and the space to come together to talk about what's going
Yeah.
on. Why are we falling out? Why are we criticising each other? I think that is a
Mhm.
sign of a failing organisation,
Yeah.
in my experience anyway.
I totally agree. And I was talking to a colleague last night, and I was saying, what makes me truly happy is I feel very aligned with what I do. And I've done
Yep.
it 22 plus years I'm now a private carer, but as a home care work, I call myself a personal assistant because we do a lot more than just cleaning and caring. But when you feel truly aligned with what you're doing, you're happy. And I think
Yeah.
that's what you see in a happy culture is, we go back to series 1, we talk a lot about people's roles and people's core values, their embedded why. And this is all really important to sort of work out from the beginning so that you're in the right position within the industry, you've got the right job, and then you create a much more positive culture, which is exactly what you're talking about.
Sure thing. And what you said is very sensible, because what it doesn't rely on is you being happy all the time, because of course you can
Mm,
be influenced by what's happened during the day. You might have had to rush to
that's
work,
right.
miss the train, the bus didn't work, the kids vomited as you were walking out the house, all sorts of things influenced when you arrive at work. So it's not that you're arriving and everything's hunky dory, and that's the issue. It's not that every day is a happy day, but it's the
No.
ability to be able to be engaged with your client, with your patients, but also the ability to be able to talk to colleagues, to
Yeah.
understand where everybody's coming from, really.
Yeah. Yeah. And it's a two-way street. I always feel, especially now in my career, I feel like I'm part of a team. So
Yes.
if you're aligned and you're happy because you're in the right position, you do feel part of something. And that also adds to your sense of belonging and creates a much more positive, healthy culture around you.
Yes.
You've led organizations, built services, and supported thousands of clinicians through crisis. What do leaders need to do practically and visibly to shift culture in the right direction?
Oh, wow. I mean, I suspect we could write a library on cultural
Mm,
shift. What do I think in retrospect I have done?
yeah.
And what I have done is be present. So it's very
Mm,
easy for a leader to distance themselves, except from the very top of the tiny executive. I think a leader has to be present, I continued in all the roles I've done to do the jobs that many of the team did, see the
yeah.
patients, answer the phone, all of that. That's the first thing, is to be present. And I think, I genuinely think I introduce a no blame culture within the organization. So I understand. And I also introduce the fact that you spend more of your time working than any other activity you do other than sleeping.
That's right. Yeah.
But you have to understand that. So work has to be fun. I don't mean fun, la la la
Yeah.
la, but it has to be a
That's
place
exactly what I was.
with a no blame. I ran a service for years around mental health for health professionals. We'd have suicides, and it's tragic when you have a suicide. But
Yeah.
what we do is we say, look, let's come together and talk about this. It's
Yeah.
nobody's. Let's check the notes, see if if we are to blame, if we have been. It's all of us, not just not.
That's right.
Yeah, and the other thing is, I try and make sure the team, I build into their service Slack so that they are able to spend those corridor moments with their colleagues. Those
Yeah.
moments, the archetypal water, water.
I know exactly what you mean.
And those are things I think I have done. And I hope that over the years I've also protected the backs of my staff. So I take full responsibility when things go wrong. It's my fault. It's not their fault. I'm the head. I put the systems in place. So I hope I've done that. And I think proof of the pudding is in the eating. We have a very, very low turnover rate. The services, particularly the primary care gambling service and the practitioner health service, have very, very low attrition rates.
That's amazing.
Very low. And people left because they get married and move. But no, and I think that's that cultural, that's what I think in retrospect I brought in.
I am going to add to what you've just said, which is I think when we go, I was talking earlier, adding on to something you said about being aligned with what you're doing and feeling happy. I think you're very aligned with what you're doing and you're an incredible leader. You're a natural leader. And I think that shows in what you've just said about, your turnover being low. And I can only applaud you on that because some people never find their place in life. And yet everybody has a place. I believe that strongly.
To tolerate in organizations, you have to tolerate people who are difficult. I once read really, again, things stick with me. And it's that you can tolerate up to about 10% of your workforce being difficult, bullies, but not everybody's perfect. And
no one's perfect.
But you can tolerate, and you have to tolerate people who are difficult because that adds grit to the organization. It keeps you on your toes and you just have to tolerate it. Not everybody comes from not everybody's going home to a nice, happy little cuddly, Enid Blyton type of background. They're going home with difficulties. They bring in difficulties and you just have to tolerate that.
Yeah. Oh, that's amazing. And I feel that makes me feel really optimistic that there are incredible leaders like you out there. Because not everybody is aligned with leadership and they're in leadership roles. It doesn't happen often, but it's brilliant to talk to you today and experience that with you. I'm going to go into section 2 now. We have just covered, I think, culture and what safe care really requires because we talked about safe spaces. But I just want to now delve a bit deeper and talk about interaction, relationships and power, which is also incredibly important when it comes to the human side of care. You said many times that the smallest interactions can have the biggest consequences, which is absolutely spot on. From your experience, how do everyday interactions share people's sense of power, inclusion, and trust?
Again, I'm going to talk from personal experience. I have worked my entire career, and I'm not a saint. I've had difficult days. I hope that people who I have interacted with, and I've had probably about 250,000 patients over the years, I have left them feeling better than when they. So I've done something good. And I'd give you an example. Often I live and work in the area, and sometimes patients come up to me oh, Dr. Gerada, you saw me for X, Y, and Z. And the only thing I care about was I kind to you? And because that's what. And once I was doing an LBC phone-in and on general practice, and the first caller was a nurse from Brighton, I can remember. And she said, "Oh, hello, I'm a nurse from Brighton." I thought, and then she said, "And you were my doctor." And you imagine live radio, and you think, "Oh my God, what?" I go back and I said, "Oh, I hope I was all right." She said, "Yeah, you were very kind," and that is what. And so what you say is, how can every interaction? I try and do it wherever. I mean, it does. Do you know what people love, and I love as GPs, the curiosity about people. Where do you come from? Not in a racist way, but where do you come from? I'm interested in you, Sadie, if time permitted. How did you start all of this? And I do that in every single place that I go because I am interested with people. I suppose that's what defines, I think, the fact that I can, with the service I run, practitioner health, I know it was a good service. I meet people all the time that have been through that. They unbelievably talk about the positive experience they had with the service, because I think the most important thing is to be kind and love your patients. And I said that to to the nursing staff at the primary care gambling service. They said, "What love?" And I said, "I don't mean love in a sexual way. There's lots of
Yeah.
definitions. I mean love. I just knowing that they know you are interested in them.
Yes.
It will
Yeah.
take much to do that. And I think over the years people try and complicate it too much rather than strip it back. And the
They
first
do.
ask is what
Yeah.
is to doing that is time, because when you are stressed and hungry, late, and all those whole absolutely
Brilliant. I love that. I love that. I wish you were my doctor. What gets in the way, do you think, of meaningful, human centered relationships in care? And what removes those barriers? What do you think?
what gets in the way is what I've said is the clicking of
Mhm.
the beeping at me, telling me I haven't done something I don't particularly want to do because it's not relevant for that
Mm.
concept. But the fear of litigation, the fear that I have
Mhm.
25 patients waiting and I'm already running an hour's late. All of those things get in the way. And as a leader, I mean, it gets in the way of everyone. I mean, care workers having only 15 minutes to go in and out. And
I refuse to do 15 minutes. I wait.
and I think that's, you talk about power. I think it's allowing people the power to say no. I can remember once when
Absolutely. Thank you. That's what we were
one
broaching on now.
moment where I really felt I couldn't deliver good enough care. I just couldn't do it. Couldn't do it. So I actually said,
Mm.
cannot deliver the care. I don't think I'm delivering. And I owned it and said, really sorry, but I won't be able to continue working in this place because this was many moons ago. I didn't walk out, but I was not able
Yeah. No, I agree.
the power to be able is to enable you to have your power to say, I'm not delivering 15-minute aliquots of care because patients take longer than, and if unless you provide me
Refuse.
force to do that, I cannot deliver it. It might only be 5 more minutes, oddly enough. Sometimes it's not a massive amount more that you need. It's just a small amount. Build you in that buffer.
I mean, from my level of care, where I'm in people's homes, a domiciliary, it's very important for us to meet people where they're at. And if they need that time, we give it to them.
Like my carer one day.
There's lots of us out there. We're all members of the PCN, so we're growing slowly, but we are really, really into what we're doing. And yeah, it is a very quite, I want to say exclusive, but that we want it to be available to everybody. So it's addressing that power imbalance is where I'm coming from.
Yes.
And actually, if you know who you are, you know your embedded why, you know where you're coming from and you're in the right role, you will be assertive. You will say, actually, this is like on my level, I will say this is how long it takes me for a washfall in the morning. And that's it. That's how long I need. And nobody argues with me on that anymore. But when you get litigation involved and policy in the county council, they start telling you what to do. That's when I go, no, well, we're not aligned. We don't work. Bye.
Yeah, and I think that's why you're so successful. By the way, my granddaughter's called Sadie, so I have a natural affinity. I think it's a beautiful name.
Thank you. It's so funny because when I hear my name, it's normally someone's old. I'm like, oh,
it's lovely. And
oh, thank you. But yeah, it's really good to hear because you're a GP. You're extremely busy. You're on a very different sort of schedule of work compared to me. To know that you say no as well and you stand by, which I know you would anyway. But it gives us all a bit of hope. So I know doctors are getting a lot of grief at the moment.
What gets in the way of change?
I think fear. Everybody's fearful of your job, fearful of what the boss might say, fearful of litigation. Even I realised in my life, everybody has what I call their point of fear. I suspect, Prince Charles or the Prime Minister, only people who are psychopaths, I suspect, don't have that point of fear. But
yeah, no, brilliant. You've supported clinicians in distress for years. You've seen how systems can either nurture emotional intelligence or crush it. What does emotionally intelligent practice look like to you in real life?
It's quintessentially what GPs do is use emotional intelligence it is what we do. So for years, I sat in the same room and would call patients so they had exactly the same distance to travel to my consulting room. And I started it, and we had a tannoy from when I said, Mrs. Smith to room 3. And I'd start it by, how long did Mrs. Smith take to reach my consulting room? Was it long, short? How did you draw what, that tiny bit where you walk across as you say, come on. Everything was attuned to her from the moment I called her. And in the moment she sat down, it was her consultation, even if there are other people, students in the room. And every sense that you have is attuned to that patient for that time that you've got, which is time. And everything about her and anybody else she cared to bring in, if it was a mother with a child, that's how. And then you listen to because patients always tell you what's wrong with them, and within the first minute you know what's wrong with them because they've told you. So that is and that's emotional intelligence as far as I'm aware.
Yeah. And following on from emotional intelligence, I just wanted to know what small, often overlooked behaviours make the biggest difference to someone's sense of agency.
For a GP, I think it's listening. Not for you, because that's different, but it's looking, it's listening with every part of your body.
From your strategic vantage point, what does good leadership look like in pressured, political, constantly shifting environments to you?
So again, I suspect, libraries have been written on that. And to simplify it would be slightly disingenuous of me, but let's try. I think in a really disruptive, uncertain space, I go back, and I have been in those positions, I go back to what your guiding light is. So what your values are, absolutely. And all of us know what your values are. All of us know so my values from the NHS and services free at the point of use, irrespective of ability to pay. So when I was leading my college and it was all chaotic, I went back to those, and that's what guided me. Now, sometimes you have to deviate from your core values. You do, because if you're part of it, but then you have to know why you're deviating from your core.
Yes, know your why. Yeah.
Know why. And I think, in other words, when people say to me years later, you said X, Y, and Z, I know I didn't say X, Y, and Z, because if I had said X, Y, and Z, it would have been clocked on so much into mine because it'd be against my core values that I would know that it. So that's what I think happens. And I think many leaders are, politically flip-flopped between what their core values are. Their core values, if you take, socialist medicine, the point of view, they then start introducing things. They don't, and then they get confused, and then the chaos.
Thank you. Sorry, I'm just really intrigued. I've got to ask this. Where do you see the biggest gaps between leadership intention and frontline reality?
Again, I'll speak for general practice. I think it's people. I think there's a drive at the moment to get out of, I'll talk about general practice, to get out of the consulting room and medicine as quickly as possible. You qualify and then you go into a leadership role. And I call it the flight from the consulting room. And I think the biggest gap is people have no grounding at all in the consulting room or in the space that they work in. And and then they think they know because they've done it as a medical student or as a junior doctor or 1 or 2 years post-qualification. They don't know. They don't know what it's like to be stressed at 5:30 in the evening when you're worried about a child, is this meningitis on a Friday evening. They don't, just don't know.
Yeah.
And they think they know, and that's the biggest gap, is they think they know, but they don't know.
They think they know. Brilliant, thank you. Quickly on to section 4. This is the future of rights, power and professional well-being. I'm just going to try and finish on some future-focused questions because your answers have been absolutely outstanding and I just want to learn more and more from you. I wish it didn't have to end. What gives you hope about where the sector is heading?
Health. Oh, because if you look for general practice, if you Google the end of general practice, it goes back to 1910. So there's always people who say, because we're always in a doom gloom situation, we always think the past was better than the future, and it never is. The present is always better than the past. and the future with the next generation of leaders. And next, I'm recently become a grandmother. Oh my gosh, congratulations.
Nathan's, I love that.
You instill hope into the next generation. So,
Yeah.
And one thing we must do is make sure as an older person, such as myself, that younger people don't necessarily want to listen. But if I say to them, one thing I would say is what I've learned is don't create rules that you think that you didn't have, that you think are needed for the next generation. They usually aren't. They usually are not. Just create the environment that people can practice safely.
Yeah.
Put constraints.
Brilliant. I love that. And you're an eternal optimist, and that's why you've been so successful. I can really see that now. How do we support the workforce to develop the craft of good care, not just the tasks?
We give them time to reflect on their work. So in terms of medical profession, the patron of doctors in distress, we advocate reflective practice. So spaces where people can come together to talk about the emotional impact of their work. And that should be a requirement for every single health and care professional.
Yeah. So reflection. Yes, you've always championed innovation, not just digital, but relational, narrative, community-based. Where do you see the most meaningful innovation coming from next?
Your specialty, of course, you can't use AI to care, can you? I can't imagine. Well, I suppose the Japanese are with robots, but
Yeah.
the next innovation has to be how we harness the power of AI. Has to be, and how we use it to the benefit rather than be fearful of it. And I say, it's a bit like if the pen was invented today, people would start putting too many rules around it. Without working out how we can get Shakespeare, how we can get all the fabulous literature that's been written. The same with AI. I think we've got to understand that we need to learn how to use it appropriately. And I'm already, and I have been using AI probably for 4 or 5 years. I mean, in some sort of way, and that's the biggest push in healthcare. But of course, for yourself, it's I suspect the biggest change for you will be how can we prevent the serious or delay the serious morbidity that the patients that you're seeing that require your care? How can we actually improve the health of people so they don't become so ill soon? As well as, I suspect, a lot of innovations that might come your way that will relieve the pressure that you're under.
Yeah, definitely. Sorry, I said it was the last question. I've got one more for all my viewers. What do you hope leaders at every level carry forward into the future?
Hope is to be hope. I think hope, it's about having an understanding that things are usually much more complex than they think they are. Lack of fear takes fear out of systems, because that's what drives bad practice. And if they are in a position of authority in terms of health, more GPs, because we need more GPs spending longer with their patients and communities.
Yeah, it's time. Yeah, thank you, brilliant. Thank you. Thank you for bringing your clarity and your courage and your decades of experience into this conversation. Today's episode, Fearness Medicine, speaks directly to the heart of Series 3, that safety, dignity, and rights aren't abstract principles. They are practices, they are behaviours, they are the architecture we choose to build. To everyone listening, thank you for joining us. I hope this conversation invites you to reflect on your own practice, your own culture, and the interactions that shape the experience of care in your world. This has been Continuing the Conversation with Sadie. Until next time, keep reflecting, keep growing, and keep caring. Thank you.
Take care, lots of love.